Okay, so then what do we do if anti-TNF medications fail? We know that from the clinical trials, only about a third of patients will enter remission from biologic therapy. About a third have a meaningful response without a full remission, and a third don't respond at all. And even of those that respond, if you follow out to a year, only about a quarter are still in remission. Mm-hmm. So it's a large percentage of patients that will need something else after trying anti-TNFs. But I think it's important to step back and think, if a TNF is failing, why is it failing? Mm-hmm. It's not always that the disease is refractory to the therapy. So there's a differential diagnosis, as you discussed, GI infections, a stricture, an abscess, a fistula, bile salt diarrhea, bacterial overgrowth, post-inflammatory irritable bowel syndrome, drug-induced diarrhea, abdominal pain. It's a huge differential diagnosis that we need to think about before we automatically switch medications.
That's an incredibly important point, and that it goes back to doing your homework. When something is not quite right, rather than leapfrogging into the next more toxic or threatening drug, is to go back and see what's different, what's new and what's different.
Yeah.
And then how often do you actually restage people, colonoscopically or with plus or minus x-rays?
So that brings up the point of mucosal healing, I think.
Yeah.
I tend to follow symptoms primarily, mm-hmm. and I think even a little bit more so in the elderly. So in other words, if I start a biologic therapy and a patient responds and is feeling well, I don't know that I'm looking in that patient for CT healing mm-hmm. if I'm not going to escalate therapy because of concerns about toxicity. Mm-hmm. So I end up having a conversation with each patient, talk about the alternatives, and if they're willing to escalate therapy if we find ongoing inflammation despite resolution of symptoms, I'll do a CT enterography in 6 or 9 or 12 months, or a colonoscopy. It depends mm-hmm. where their disease is located. But if they're happy with their symptoms, I just saw an 80-year-old guy yesterday that has ileocolonic Crohn's disease. He's on adalimumab monotherapy and feeling much better. A little bit of abdominal discomfort, a few days per week that lasts for 20, 30 minutes, but he's overall very happy. He doesn't want to escalate therapy. He doesn't want to add a second agent. So I elected not to pursue a CT mm-hmm. scan.
This is an incredibly important point because of this drive that we have now for mucosal healing from all of the pundits and all of the studies, that mucosal healing is a necessary part of feeling better and improving and preventing complications, except in the older population. I think if we can remember a few things, that symptoms trump mucosal healing in this population. And the other caveat we teach our fellows and residents is don't destabilize. For the risk of getting an improved mucosa, you may throw someone into a funk that they can't get out of. And particularly if you're going to prep them for colonoscopy, the prep alone can be very damaging and sometimes irretrievable.
Yeah, in general, I agree with you, but I think you have to individualize, of course. Right. If you have an older patient with extensive small bowel disease who you're worried about long-term outcomes, I might look for a follow-up scan even if they're feeling better, but that it would be individualized. So if you've worked through the differential diagnosis and you find no alternative explanation for the symptoms and the patient is truly failing their current dose of anti-TNF, either increasing the dose of the anti-TNF or decreasing the interval between doses has been shown to recapture mm-hmm. some response. In addition, an immunomodulator can be added, so going from monotherapy to combination therapy with the concerns we've discussed already. But remember that the immunomodulators are slow onset drugs, and if a person's having a flare, they often would need steroids to get them through while the immunomodulator becomes effective. Then they're on triple immunosuppression for a period of time with probably greater risk of adverse events. If they don't respond at all to anti-TNFs, other options include natalizumab, a different mechanism of action, surgery, and sometimes a clinical trial.